friends of these meetings, and I really appreciate her asking me to speak today, and I hope this will give you some good updates about what we learned. I feel like when I go to these meetings, I have to be an ambassador for what we know because I hate that everybody can't go. So I've tried to summarize the key things with this. I also want to thank the Canadian Fabry Disease Association for inviting me here. I've done a kind of, these are my disclosures. I work in Fabry disease, so I work with a lot of the companies that do treatments for Fabry disease, doing my own research and then clinical trials and working on educational grants so we can hold meetings. There was so much information that we learned at these meetings, and there's so much information we've learned around these meetings. I really tried to pick the highlights that I thought might be the most interesting to folks with Fabry disease. So full disclosure, this is not everything about Fabry disease that happened at World. Some of the stuff with mice and rats and cells will be so cool, but I think maybe we'll learn more about that when it moves into the human space. This is kind of what I'm going to cover. I'm going to go over a little bit about Fabry disease just so I make sure we're all on the same page, because the things we learn at World tend to use a lot of abbreviations and a lot of assuming you know what's going on with things. So to me, this is really important when we think about what's going on. We'll talk about what we've learned in women in Fabry disease, kids in Fabry disease, approved therapies, and therapies in clinical trials. But before we really start, I think it's important to take a coronavirus moment. I've been getting a lot of questions from patients I work with here in the United States about what does this mean for people with Fabry disease. So the good news is that in Canada, you have a great public health agency, Public Health Canada, and they've got great recommendations. But I just wanted to do a couple reminders. Really, this is a virus they expect is mostly going from person to person, from respiratory droplets, that'd be sneezing, snot, that kind of stuff that passes from hands to doorknobs into faces. When we talk about Fabry disease and COVID-19 or coronavirus, we're mostly worried about folks within our Fabry community who have heart disease, not just bradycardia, but actually left ventricle hypertrophy or other forms of heart disease, diabetes, and lung disease. So in our Fabry community, that would also be people who had transplants and are on steroids or are immunocompromised, whether from medications or some other reason. So that actually means the vast majority of people living with Fabry disease are not at increased risk of getting very sick. They're the same risk as everybody else. Oh, I should also mention they talk about people who are older adults. They usually mean 65 and older when they talk about older. Not that I think 65 is old, but that's kind of the cutoff they use when they talk about older adults, particularly on Health Canada's site. There's a great website. The Health Canada site, I think, is so useful because they update it on a regular basis, and they also give recommendations for what to do. But many of these things are very much what you would do anyway. If we end up at the point where we all want to have limited contact and have to stay at home, you want to talk to your doctor to see if perhaps you can have some extra doses of medication if you need them so you don't have to leave your house. Making sure you've got acetaminophen and Motrin are the things that help reduce your fevers and things you need for any illness, whether it's a cold or a flu. And then the frequent hand washing, as you might expect, and avoiding contact with people who are sick from about 6 feet when you're out in crowds, which means probably being at home a little bit more. And of course, there's big recommendations on avoiding cruise ships, because I'm sure we've all heard about them having to evacuate ships and repatriate people and keep them for 2 weeks in places. So what next? If you think you're affected by COVID, that's when you'd call your doctor. And the only reason you'd really go into the hospital is if you have these serious symptoms. So real difficulty breathing or shortness of breath, persistent pain or pressure in your chest, confusion or unable to wake somebody up who has this condition, or bluish lips or face. It means they're not getting enough oxygen. So that's the warning signs you would think about for anybody, whether or not they have Fabry disease or not. But really making sure your doctor knows if you're sick, and then if you have these serious signs, that's when you go into the hospital or the medical center. Okay, that's my only COVID moment. I know we probably have heard too much about COVID at this point, but I thought since I'm getting a lot of questions, you might want to hear a little bit about that as well. The bottom line is, wash your hands a lot. And if you've got pulmonary or heart problems, that's when, or decreased immune system, that's when you want to pay more attention. Okay. Many people with Fabry disease have this down cold, but sometimes we've got people who are new to the space, or there's been terms you've heard but never really fully understood what they are. So I thought I would take a few minutes to really talk about what all that, the baseline stuff is before we go into the big stuff. So cells are the little units that make up our body, and they have genetic information in them, but they also have all the other things we need to transmit oxygen through our bodies, grow, develop, and use our food. We also, cells come in special kinds, and one special kind is called the endothelial cell. That's the cell that lines the inside of blood vessels, and it's very important because it's in almost every organ and part of our body. There's also cells called podocyte cells, which is just a special kind of cell that's in the cells of the kidney, and it looks like little spiders, but its job is to filter out protein and other things within the kidney. And these endothelial and podocytes are particularly important when we talk about Fabry disease and treatment. The lysosome is within the cell. It's the recycling center of the cell. And that's where the enzymes that we talk about in lysosomal storage diseases like Fabry disease live. The enzymes that are within those lysosomes, we have the instructions for them in our genes. And the GLA gene, which is the one that when it's not working causes Fabry disease, is on the X chromosome. And it makes alpha-galactosidase A when it works. And if it has a change or mutation, that's where it doesn't work. GLA. GLA codes for enzymes, which are kind of like scissors that are in our lysosomes, and they break down big molecules. And alpha-galactosidase A is the enzyme that when it's deficient causes Fabry disease. Alpha-galactosidase A's job is to break down these big molecules, these gunky molecules we call globotriacylceramide or GB3 or GL3 and globotriacylsphingosine. That's lyso-GB3 or lyso-GL3. Depending on what country, and it's more GL3 versus GB3. And so you'll see in the studies, it really depends on where they are, whether they call it lyso-GB3 or lyso-GL3. So this stores up in the lysosomes, and you can see in this picture here with the red arrow, that's what it looks like when this lyso-GL3 and glycolipids store in the cell. So that stuff that stores in the cell, it builds up in those endothelial cells we talked about and narrows the blood vessels. And that narrowing of the blood vessels is what causes all the problems. But it also, the narrowing and the storage of GB3 or GL3 in particular, irritates the body. It causes inflammatory reaction, and that leads to problems with cells being able to function, develop, and often cell death. So it's not just the storage, but it's also everything that comes after that. And to emphasize that, I have this really big slide, I'm sorry, but it's basically just showing you that plasma lyso-GB3 actually acts to irritate or inflame the cells and make them kind of give out screams of help to the rest of the body. So they start attacking cells and leading to scarring. So it's not just the storage, but it's also this call for help the cells make, which is worsened by lyso-GB3. When we think about Fabry disease, people are hearing more about what we call classic Fabry disease and then non-classic or later onset Fabry disease. It's important to emphasize that all of these types of Fabry disease are serious. All of these are life-impacting. About earlier onset, we think about pain in childhood, and we think about a path that goes directly
Hey, Dawn, it's
Fabry
Juliet.
disease. We think still about, yeah.
You just cut off a little bit there. Do you mind just, I think it maybe just the last 30 seconds or so. Will you mind just backtracking a little bit?
Okay, sure. Yeah, sure. So when we look at, yeah, of course. When we look at classic Fabry disease, we're thinking about Fabry disease that begins in childhood with pain, with lack of sweating, with maybe those purple spots, those angiokeratomas, and follows a pretty predictable path without treatment leading to protein in the urine, kidney problems early on, heart disease, and strokes. When we think about non-classic Fabry disease, it's very serious. It's not something that we consider as problems, but maybe not having all the problems you'd see in childhood with classic Fabry disease. You may still see pain, you may still see kidney problems and heart problems, but more typically, there's a little bit more enzyme so that people are able to avoid some of that horrible pain and the GI problems in childhood. And now it's on a spectrum, so somebody may have symptoms like that with non-classic Fabry disease. And at this point, we just need to think about it as, you know, the most severe form and then all kinds of people in between. And the only way to know what's happening with somebody is really looking at them from head to toe and looking at what's going on in their family. When we think about new stuff we've learned about Fabry disease, at this meeting there was a large focus on Fabry disease in the heart. And the reason for that is that we know that Fabry not only affects how the heart is made and functions, so its structure, but also affects how it functions with its rhythm, with its conduction, and how it moves blood through the body. Cardiac MRIs are so critical for learning what's going on in the heart, because sometimes an echocardiogram combined with an EKG may not give you enough information about changes over time. Usually an echo does a great job of seeing if the left bottom chamber of the heart is enlarged. It does a good job at looking at the valves, but it may miss some changes that are going on subtly that are easier to see through a cardiac MRI. So there was a lot of emphasis by Dr. Jeffries and Dr. Gavin, really focusing on how the cardiac MRI can be very helpful. They also talked a lot about arrhythmias and how rhythm changes in the heart that can be bad, like fast rhythms, sometimes are not caught when you're doing a normal Holter monitor for 24 hours. And they've been using a loop recorder, which is just a little recorder that stays in your body. It is implanted under the skin and stays in there for 3 to 5 years, and really it does a great job of picking up heart rhythms that might be a problem for you. Because those heart rhythms are really one of the most worrisome things about Fabry disease as you get after 40 years of age. And there's also some good discussion about how you avoid beta blockers if you can, and that's working with your cardiologist to find a medication that's better to treat high blood pressure and proteinuria, maybe looking at an ARB or an ACE inhibitor, which are just different types of medications that do the same thing. The problem with the beta blocker is it causes problems with how your heart rhythm is forcing the blood out of the body. At World, we learned a little bit more about the kidney. It's always a good idea, even though we think we know why kidneys fail in Fabry disease, to really do a very deep look. And that's what happened with a couple posters and presentations. One of the things we learned is that it's not just the storage of the GL3 or the gunk in the kidneys, in the endothelial cells line the kidney, in the podocytes, the filtering units itself. It's actually that lyso-Gb3 we talked about earlier that also increases stress and inflammation. So there's the storage and there's scarring, but also that lyso-Gb3 is really causing problems as well. So that was not new information, but I think stronger information, because this idea about lyso-Gb3 really being a stimulant of problems is new to everybody, and that's what they've been working on. We talk about another presentation was really interesting. It was looking at men's biopsies with classic Fabry disease, women. All right, so the study was in women with classic Fabry disease, but they found the same thing in men previously. They just found a new method to be able to figure out, because women have some cells that have enough enzyme and don't store things, right beside cells that don't have enough alpha-galactosidase enzyme and do store things. So usually what they see is GL3 filling more and more and more of the podocyte cells. And when they did a study in men, they saw that this cells get full of GL3 and get bigger and bigger until they're about 27. And the cells are so stressed, you start losing them. So what they said is that we need to understand that storage is a problem, lyso-Gb3 is a problem, but you come to a point where those cells start being unable to filter. They start going from being like nice finger spider. Let's see that again. Sorry, I don't know why my internet connection is so. So the podocytes go from nice finger-like spider legs where they can filter out protein to flat like cement, and they don't work as well. So what they're saying is when they looked at cells, age 27 is about when things got really full, really big, and after that we saw more podocyte cells just being unable to handle the stress and losing them through your urine, so podocytes dying and not being able to filter anymore. So for them, that was one of the main causes of Fabry disease, related kidney failure, but also something that tells us that we need to start therapy before that age 27 on average in these classic Fabry guys. Not that it won't help later, it's just that if we really want to save as many podocytes, we need to start before the full damage is occurring. So that's one of those great studies that's trying to figure out when do we start therapy. This was started out with me saying, well, look at this. They made a Fabry mouse that couldn't hear. How interesting. But it actually came out with, they made a better rat that's more like patients with Fabry disease because it has more of the symptoms, and more of the symptoms has this progressive hearing problems. And when they looked at where the GL3 or the gunk was storing, it's in the nerves of the ear, and it's the wall that secretes some important things into the cochlear area. So it tells us that the hearing loss we see in Fabry disease is what's called sensorineural, and that's the most common form of hearing loss of any kind. But it was just the first time we've had a good way to look at hearing loss in Fabry disease, in this case in a rat. This is a paper I did, but I did it with a woman who has Fabry disease who actually came to me and said, I want to talk about this more. And what we did is a case report when she was having a pain crisis. What she has found is she goes to a flotation tank where they use Epsom salts, which is magnesium sulfate, and she lies in there in a sensory immersion tank. In the quiet, it takes her pain level down from like a 10 to more like a 3. And we found a possible mechanism based on the hypothesis that the stress levels are so high and the cortisol levels are low, and within these tanks, cortisol levels go up and stress comes down, which helps with the pain. It doesn't make the pain totally go away, but it helps your body better handle it. And this is something we've heard in several patient support groups. So it was interesting to talk about this. And she was presenting the slide and she was so busy. It was amazing. Everybody wanted to talk to her about this flotation and looking at an alternative medical way to really help with chronic burning pain and pain crisis. It, of course, needs a lot more work before we could recommend this, but it was interesting to see one possible mechanism for this working. There was one very interesting paper by Hossein et al. That was presented, and it was looking at how do we know which women are going to have more severe problems with Fabry disease. And most people know that women, before we're born, we have 2 X's, and one X for women who have Fabry disease tends to have that one non-working GLA gene, and the other one has a working GLA gene, and one or the other of them turns off at random, and we usually end up with half our cells that have enough working GLA genes, and the other half doesn't. And they would say on average, we'd expect to have a certain amount. But this study, when they looked at 75% of women, they found that the more genes that have no change or a working GLA gene when they get turned off, then the more likely it is they're going to have more Fabry symptoms. So it makes sense, but it's a way of doing a test early before people have symptoms to say, okay, more likely this woman has more of her non-working GLA genes turned off, so she's not going to have as much disease. Well, this woman over here has more of her working GLA genes turned off, and therefore she'll maybe have a little bit less disease severity. But again, you'll see it was 75%, so it's not perfect. We still have to look at each woman individually, but it was a nice start. It's a nice another clue that could help us figure out if there is a woman who will not have symptoms or have a less likely chance of having symptoms. Which would be nice to predict, particularly if we're looking at newborn screening. The formal way to say a gene is turned off is that it gets methylized or methylation. Methylation is just a fancy way of turning off a gene. A methyl goes and says, you're not going anywhere. So if you hear methylation or methylation, that's what they're talking about, turning off genes so they don't work anymore. This is actually from the poster I presented in young children with Fabry disease. One thing that in my head I always thought was happening is that as babies grow older into teenagehood and adulthood, I expected to see that the GB3 levels in urine would go gradually up. So more disease, urinary GL3 is increasing, whether if it's total urinary GL3 or parts or pieces of that. And the data that we looked at, which looked at children under 6, showed a more flat level. It wasn't statistically significant, but it seemed to be more stable from birth to age 6, as opposed to gradually going up, which is what we expected. So that means that we may not be able to take one sample a year and decide when somebody should start therapy. That won't give us what we need to know if that's a way of starting kids on therapy. All right, what did we learn about FDA-approved therapies? As you might expect at these meetings, you never know if you're going to get a lot of studies on the FDA-approved product or not. In this case, we looked at agalsidase alpha, Replagal. And there wasn't as much data on this particular drug. It's been approved. There's been lots of good publications in the past. But one thing they did find from Darrell and Hughes's paper was that if you start agalsidase alpha treatment earlier, then you have a better chance of having better heart and kidney outcomes. So the longer you wait, the less effective agalsidase alpha is going to be. So that it makes sense. It's not a data point that is really shocking, but it is something that it's important to emphasize. And they basically learned the same thing with agalsidase beta. There were 3 studies that were presented here. One was showing that over time, taking agalsidase beta, enzyme replacement therapy or Fabrazyme, stabilizes heart and kidney disease, or at least it slows kidney decline. So it's not, it doesn't, if something's irreversible, it's not going to get rid of it. And it did emphasize that it's more effective if it's begun earlier before the changes are done. So if you link that with Dr. Najafari's paper on classic Fabry disease in males, then you will see there that it does get to a point, whether it's 27 years on average or not, that it slows the decline. And they also found that from the registry, treatment for 4 to 5 years of enzyme replacement therapy is associated with less belly pain and less diarrhea. So that was good to see as well. I think these are not shocking, but again, once a treatment is approved, you don't tend to get shocking things. There was some interesting information on enzyme reactions that came out. I think this was also from the registry. They were looking at people who'd had agalsidase beta, that's Fabrazyme, and whether or not they developed antidrug antibodies to enzyme replacement therapy. And they did find that men have antibodies more frequently than females, and that over time, most of those individuals who develop antibodies, they start going down again. So that most individuals, male or female, who get antibodies, over time they decrease. Now, they couldn't say how that affects effectiveness of the treatment at that point, but it's just one more step in us learning more about immune reactions to ERT and how our body reacts, and what we need to do to make sure that we're getting the maximum effect of enzyme replacement therapy, particularly in someone who has antibodies. So stay tuned for that. There was migalastat, otherwise known as Galafold. There was a couple interesting studies. As you know, it got approved in 2018 in the US and around that time in Canada, I do believe. But they did a couple nice real-world studies were presented. One of them is showing that when you use this in your patient population in the UK, that there are minimal side effects, and they treated people who'd never been on therapy before, and it showed to be effective in reducing lyso-Gb3 and left ventricle size. So that was great. And that was also for people who were on Fabrazyme or Replagal and then switched to migalastat, that it seemed very, causing stable to reduced issues. When we look at another study that's from Schiffman, he said, when we looked at the data, this was from the migalastat trials, when you looked at how much the lyso-Gb3 went down, it didn't mean that it also correlated with the amount of pain going down or the stability of GFR or left ventricle going down. So what it means is you can have lyso-Gb3 and it can go down some and you can have really good impact on the heart, or it can go down a lot and you can have stability in the heart. You just can't say, ooh, if my lyso-Gb3 levels went down 4 points, my heart size also went down X number of points, or my GFR stayed stable or went up for this many points. They don't connect directly. Now, we do see it going down with migalastat and enzyme replacement therapy. But again, it's not like a one-to-one, this happens, so this happens. I got this lab level, so this is happening in my body. It just doesn't work that way. I wish it did, it'd be easier. They also looked at kidney, this is Dr. Najafian again, doing great studies in renal biopsies with a team of expert folks. And they found that after 6 months of migalastat at the standard dose, which is actually 135 milligrams, I put 150, but it's actually 135 milligrams every other day, men and women both had reduced storage in the kidneys and the podocytes, those deep filtering units we talked about, and the capillaries. So that was good news. So that, again, showing the kidneys are being helped with migalastat. Okay. So what's out there in clinical trials? Well, when we think about clinical trials, we think about all the different steps that these enzymes in Fabry disease have problems and all the places we can help it. And we've just talked about the FDA approved enzyme replacement therapies. Oh, sorry, in Canada, they wouldn't be FDA approved. We talked about the regulatory approved for marketing in Canada for alpha-galactosidase, agalsidase alpha and agalsidase beta. And you can see it where that would be. That would be just replacing the enzyme that's missing. We also talked about the one approved chaperone that helps some individuals with minimal mutations who need stability of that enzyme or that protein so they can get into the lysosome where it can do its job. So really helping it get through the control mechanisms. But one other exciting, couple other things we're looking at that are really exciting, it's gene therapy. We also look at substrate reduction therapy. Gene therapy is having your body make an enzyme, whether a factory or integrated to its own cells, to act as if you were making that enzyme yourself, really trying to make a factory of enzyme in your body. When we think about substrate reduction therapy, we're trying to find alternate paths to decrease the amount of gunk that builds up in the cells. So that's substrate reduction therapy. And there's other things they're trying to, like stop codon read-ons. That would only work for people who have stop signs in their gene on a stop codon read-through, but it was still in cells in mice. Hold on, I see my connection just did something funny. They looked at mice and looked at cells and found that there's a medication that's been out there for a while that may help, goes through the gene, hops over the mutation that's a stop or nonsense mutation and keeps on reading. And they're giving, that would give somebody some workable enzyme to use. But again, that's nowhere near humans yet, so I didn't emphasize that one. Substrate reduction therapy, Sanofi Genzyme has substrate reduction therapy that went through phase 3 trials, and we're waiting for the data on that. It wasn't presented at this particular meeting, but we know it's out there and hopefully will come down the road soon. But there is open, and they didn't present much data either. Idorsia has a phase 3 clinical trial that's open, and it's looking at a substrate reduction therapy, again, trying to have alternate paths to make sure the gunk doesn't store up in the lysosome. And they're looking at patients who have some pain, and they measure that and figure out whether somebody qualifies or not. But those are phase 3 trials that are open in several countries, including Canada and the US. There was also some great presentations on next generation enzyme replacement therapy in clinical trials. Unigal, or pinganalcidase alpha, is now in the phase 3 trials, and they're fully enrolled and just trucking along. They hope to take data to the FDA and other regulatory agencies in the next couple of years. But the data they did show was from the original study, the phase 1/2 study. And the goal with Unigal, or this medication, is they modified it so it's supposed to stay in the body longer and hopefully not affect the immune system as much. And that's what they're trying to prove. Was it safe and effective, and did it have a reduced, does it stick around longer? Is it safe? Is it effective? And does it have a less immune reaction? So you can see here, they looked at data with 3 different doses, and it was given every 2 weeks in the study in men and women who'd never been treated. And they found a significant, profound reduction in the GB3 in those kidney cells and the levels of plasma GL3 rate, showing that for people who'd never been on therapy, taking Unigal did have a significant decrease for them in kidney storage and in diurnal plasma storage. So that's what they presented. But again, their phase 3 data is in the works. I'm sure they'll do an interim analysis for next year. Okay, so gene therapy is like the sparkly rainbow kitty that we all really, really want. And the good news is there was lots of good starting data that we saw at the World meeting. But I want to remind everybody that the goal of gene therapy is to take the cells or transform the cells in a way that you make your own alpha-galactosidase A in your body. And you want it to clear those GL3s or lyso-GL3s. That's the goal. And we want it to happen for as long as possible. How do you do it? Well, there's different mechanisms, and every company is going to have a slightly different mechanism doing it. But the 2 ways we think about it most are cell-based. So you take cells from the body, you change them and put them back in the body. Or you send the vector, or what's going to change the genes or add the genes into the body. So we call it cell-based delivery or ex vivo, or direct delivery, which is in vivo. That vivo just means body. Outside the body is ex vivo. Inside the body is in vivo. When I say vector, I like to think of vector as like, this doesn't sound great, right? But like the mosquito that brings the gene to your body. That's what a vector is. And there's different types of vectors. There's some that are viruses that they took all the guts out of, and then they were able to send that in the body and transform the cells. And some that, like a lentivirus, which is just a different type of vector that you put in as well. So these are just, a vector is just a way to get something in the body. It's like a direct pipeline. How do you know if gene therapy has worked? These are the type of measurements you're going to see people doing in clinical trials, trying to prove that it's effective. They want your alpha-lactosidase A levels to go up and be high. You want them to be higher than a certain level that we don't know yet, but definitely higher than someone with non-classic Fabry disease would be the goal. You want to get the gunk that stores in the cell down, and you want it not only in the blood, but it would be great to have the kidneys and the heart and everywhere else in the body. We want to see results where the kidney function stabilizes and heart function continues to be good or stabilizes. And we want to see minimal side effects. We don't want to see any increased risk of cancer or massive immune responses. And then we want to know how long it lasts. So these are all the things we're going to look for, both objectively and subjectively in a clinical trial to see if gene therapy is working. There are so many people working on gene therapy. It's wonderful. New companies pop up every 5 minutes. The 4 that are furthest along clinical trials, though, are AVROBIO, Sangamo, Freeline, and 3 of these companies are enrolling in their clinical trials. 1 is getting close, and this started enrolling people in the natural history study that's going up. And then we know Amicus, Bluebird, some other ones are prepping to do work as well. So it's going to become an interesting crowded market, and I think it's going to be very interesting to see if there's one gene therapy that seems to work best, or different gene therapies work better for different people. The program that's furthest along, and actually started with you guys up there in Canada, is lentivirus at AVROBIO. So lentivirus is the vector. This is an ex vivo gene therapy. So you're going to take cells from someone's body, take them out, put them in a petri dish, transform them so that those cells then can make their own alpha-galactosidase A, going to dampen down the person's immune system, and then give them the lentivirus back in so that it can go in there and make enzyme for the person's body. The dampening of the immune system has been done with 2 different agents, and now they're working on their 2nd agent, and it's been working pretty well. And the other thing to know about this is that AVROBIO does recognize that this can take up a man's fertility. So they bank sperm at their own cost, and then they have some programs around that. They've been doing this now for almost 5 years. And the initial study they did was in 5 individuals. This was phase 1, and it was all with you guys in Canada. And they showed alpha-galactosidase level up. Remember, that's one of the things we want to see. And they saw plasma and GL3, GB3, and lyso-GB3 down. And it's happening for at least 2 years after gene therapy for those earlier guys. So that marks some of our boxes there. Also, they didn't see any massive immune reactions or significant side effects other than what was expected from the dampening of the immune system. They call that conditioning. And then also what they'd expect with someone with Fabry disease. And those individuals were on enzyme replacement therapy, and gradually they got off of the enzyme replacement therapy, and their alpha-gal stayed up. So that was great. That's wonderful. So they went into the phase 2 clinical trials, and those are open in Australia, Canada, and I think they're almost open in the US as well. And they reported results at this meeting on the first patient. And the first patient had a reduction of GL3 storage in their kidneys at 48 weeks, so almost a year. And they also had increases in alpha-galactosidase A level in the leukocytes and plasma, so that cells in the blood and then the blood themselves. And they had a significant decrease, 87% reduction in the storage of things in the plasma, urine, GL3, or GB3 and lyso-GB3. So that's great. It tells us in the kidneys things were getting cleared out, in the blood things were cleared out, and the enzyme level was up. Also in the safety front, they didn't see any massive emergent adverse events with the conditioning or immune system dampening, and no serious adverse events. And so this was Volk et al.'s presentation, but really this is telling us this is one method that appears to be working well so far. But again, we have to see how long it lasts and make sure that in other individuals, because this is, in just a small number of people, how well it works compared to other different things. But how amazing, how exciting. That's like the beginning of our rainbow kitty. The other ones that I'm going to talk about are using a modified adenovirus vector. And what happens in this case, they put the gene they want to express into this vector and inject it into the individual, and tends to target different parts of the body. So we've got two that target the liver. They're going to go in there, make a little circle of DNA, and they're going to try to make the liver into an enzyme, alpha-galactosidase factory, and make as much enzyme as it possibly can. The next one is targeted to the heart, but it also hits other parts of the body. Again, just trying to make that organ a factory that makes as much alpha-galactosidase as possible. Sangamo gene therapy is one that's already open for enrollment in their phase 1/2 clinical trial. That means this is first in humans for them. This particular study is focused on trying to make the liver a factory, and it uses this recombinant AAV, or adeno-associated virus 2/6. I think that's going to be best for going into the human body. They're calling it the STAR study right now. The data that they were able to present at this point was just from mice data, and they saw that it made therapeutical levels, or high enough levels, of alpha-galactosidase A. So next year they should have some data present for us that looks more at humans and what's happened in humans, but this is what they presented. It was kind of the design of their study. Freeline is another one that's using AAV. It also has enrolled individuals in the study, just one that reported this study from Daryl and Hughes. This is another AAV gene vector, which means they're injecting into the body, liver focused, trying to get to the liver to make a liver factory. It's phase 1/2, so we're looking at how safe and effective this will be. They did talk about the mice data, and they found that this enzyme was showing up all over the body, and it cleared out kidneys, heart, and their lysourinary GB3 and GB3 levels went down. So again, showing that in mice, we're doing a great job curing mice here. Next, we're waiting for humans, but they were able to show data on one man who did gene therapy with the AAV Freeline vector. And so they are enrolled. They did really well, no massive immune reaction to this vector, and they didn't have much data on how much things decreased, because it happened really recently to when this happened. But again, since our two things are safety with a backseat on effectiveness for this type of 1/2 study, that was good news as well. So great, two possible things going on there. Okay, so at this point, I'd love to answer any questions you have. I feel like I've been running through that pretty quickly. So if there's one area that you would like me to focus on, I'm happy to go back and answer some questions there. Yeah, Julia, anything you have to ask?
Hello,
Hi.
can I ask a question?
Of course.
It's Lori speaking.
Hello.
Has there ever been any studies on the effects of possible effects of liver being affected by long-term enzyme replacement therapy?
Mhm. That's a great question. So I've always been curious on why the liver is not as affected by Fabry disease as we would expect. And so I actually asked Dr. Bob Desnick at a meeting. I was like, why is it affected? He's like, I'm not really sure. It just isn't. So we haven't his focus as much on the liver and Fabry disease because it had been such a problem for us. But I think at this point, I haven't seen any good data on long-term enzyme replacement therapy in the liver. I haven't seen the evidence of in my patients. I take care of about 100 Fabry patients. There's more within my team too, but I have patients that have been treated for a really long time. And I haven't seen any increased problems with liver functions or livers unless somebody gains a whole lot of weight. Because when somebody gains a whole lot of weight, their liver can become a little fatty as well, just like your body. And that's the only time I've seen anything related.
Oh,
But not so far.
okay.
That's definitely something to talk with your doctor. If they've seen anything. But good question.
Yeah.
I also have those questions about the.
Yeah, you would think, just because we have so many other areas within the body that I know the areas that we know that Fabry affects, but I'm always wondering outside of those areas, are people exploring if Fabry affects other areas of the body that aren't generally obviously impacted, but maybe in years to come or something down the road, people start to see different types of symptoms that maybe not be associated to Fabry, but maybe possibly could be.
Mhm.
So
Yeah, I think that we've
the
been,
liver was just one.
yeah, and I feel like talking to you guys is where we learn those things, because one of the papers we really worked on and studies that we did, myself and a psychologist that works with us, was looking at depression and anxiety, which wasn't originally really well described in Fabry disease. And then, we started looking more here, and we started looking at the nerves to the intestine. So I think, I think about Fabry and teeth a lot. But these are things that when you guys bring them up, then our brains start thinking, and then different people who work in that area can help. My top thing to figure out right now is edema.
Are you there, Dawn?
I'm here.
Oh, sorry. Edema? Sorry, you were just saying edema?
Yeah, edema is my biggest thing I want to figure out in Fabry disease right now.
Okay, sorry, what's edema?
That's when you've got that puffiness or fluid-filled feet and ankles. And you may have,
oh, right,
some
yes.
people have a lot of that. Yeah.
Okay. Okay. Yeah, I've often wondered about, the female reproductive system. Have doctors looked at that with respect to Fabry? Edema for sure. That's another area too. Yeah, so it's always interesting to come to these meetings and learn about what you've learned and what you're sharing with us today. So thanks very much.
Sure, thank you. I can tell you that I had a student who looked at pregnancy in Fabry disease because we were worried that we would see more miscarriages or more complications in Fabry disease with pregnancy. And we were very reassured. We looked at many, many pregnancies, and we did find that people's pain sometimes increased and their protein in their urine increased, but we didn't see increased problems with miscarriages, strokes. Although people have had strokes during pregnancy, it's not something we saw routinely. So that was pretty reassuring. I tried to do a study on menstrual cycles because I was curious, and that one just never came together. But pregnancy did, so that was good.
Dawn, let me ask you about teeth. Are you talking about the nerves with respect to teeth specifically, or what are you speaking about when you're talking about teeth?
So we know that in Fabry disease, sometimes people have decreased calcium in their bones, so osteopenia, osteoporosis. And I wonder about the teeth, because here in my population, we have a lot of people who have a lot of cavities, even with fluoride and brushing teeth, or have a lot of problems, so they end up losing their teeth early, like when they're in their 30s, and end up with dentures.
Yeah.
So I would like to learn more about that, but I need a dentist to work with me, somebody who's really, good and interested in this topic.
That would be so cool, because at a young age, I started to get a lot of nerves starting to die in my teeth.
Ooh.
And I was having, what's it called when you have to get the implants put in? A root canal. I had so many root canals when I was a kid. And I'm like, what's going on? I shouldn't be having these till I'm like later on in life, I thought. But it was interesting because in my childhood, in my teens, I think I had about 6 root canals by then. So that was kind of like, I've always thought about teeth as well, quite honestly. But, and cavities too, very susceptible. And I have great hygiene, and I'm like always being nailed at the dentist. So yeah, that would be really cool to focus on, Dawn.
Yeah, things to think about, right? I have a list on my whiteboard.
Right. Yeah, I can imagine. Well, thanks. I don't want to take up too much of everybody's time. Thank you so much.
You. Yeah. Who else has questions? I'm happy to
Thank you, Lori. That was a great question. If anybody else has questions, just if you look to the bottom of the screen, you see the chat. If you click on that, Donna asked a question, but also if you have any, just type it in the area below, and then Dawn can answer there.
Sure. So I have a question here about exon activation. So I'm going to go back up to that, and other people can put stuff in there while they're thinking about it. So, so if we think about women with Fabry disease, if we know that Fabry disease is typically only on one X chromosome. So you've got 2 X's, and only one X has Fabry disease in GLA, and the other one is just a standard working X in GLA gene. And all women before we're born one of our X's turned off, and it's supposed to be random. You're supposed to end up with about half of one exon and half of one X, the other exon in the cells of your body. But one of our theories has always been that women who have kidney failure early, or women who have heart failure early, or women who have lots of pain or a lot of digestive problems or a lot of fatigue, that maybe in those particular parts of their body, the X that has a working GLA gene is off more often. So like a calico cat, you've got patches of enzyme in your body, and that particular organ did not get enough enzyme. So what they did in this study is they took blood from women and they looked at how many people had a specific level of symptoms and how high their GLB3 and how high their lyso-Gb3 was, and if that matched, having more normal X's off in the cells, if it matched with also having more severe Fabry disease, which is kind of a weird concept to think about. But they were just trying to figure out if they could do a blood test and figure out how severe somebody might be, looking at which X's were off and on. So if you've got more Fabry disease carrying X's that are on, leaving the ones that have working genes off, then you'd expect more disease. And that turning off process is called methylation. It's just the fancy name for sticking something on the gene that tells it not to work. That's how we turn off our X's. Men keep their entire X going the entire time because they have a Y and an X, and that Y doesn't have the information it needs. So it keeps the whole Y and the whole X, basically. So it's kind of interesting. Did I answer your question? Comments here. Okay, good. Excellent. What else can I answer? Oh, eligible for gene therapy. Okay, so each of these studies that I've talked about, you need to figure out what the exact requirements are. Most of them right now are only enrolling men, and each study is a little bit different. For example, the 4DMT study, it takes people who are on chaperone therapy or enzyme replacement therapy and can have non-classic Fabry disease. And that one is going to be a more broadly open study, but only in men. If you look at some of the other studies, they'll take Freeline at this point is only open for men who've never been on therapy, who have classic Fabry disease, and they do that based on the gene mutation. If you look at, I haven't seen the AVROBIO ones in a while. I think they were also taking men. I can't remember if they were naive to therapy or not, but if you talk to your genetic doctor, or you can talk to somebody who's doing the study themselves, and if you email me, I can tell you who's doing the studies. They can tell you the specific, are you eligible or not, from the very beginning. And then you go through a screening visit, and in that screening visit, they figure out, oh, do you have an immune reaction to this lentivirus or this AAV or alpha-galactosidase A, and then or do you have liver problems, or is there anything else that might take you out of the study? So the first thing to do is just, you can look up online, it'll tell you what the criteria are, but sometimes it's easier to talk to your doctor and say, hey, would I qualify for this gene therapy study that targets the liver? Or hey, would I qualify for this gene therapy study I heard about from AVROBIO? And I actually, Julia could probably help you navigate that a little bit as well. Just to know the very base, if you meet the basic criteria. Now,
yeah,
some of the
sorry. Oh, yeah. Sorry, I don't think that you can see my video. But yeah, please reach out if you have any questions about the gene therapy trials. You can reach out and I can give you some of that, just the screening information, and if you'd be eligible. So feel free to contact me about that, and I can put you in touch with other people that will help you further along the line.
Yep, perfect. Yes, always a good resource. And the other thing I would say about that is that some of the companies are looking directly to go into women as soon as they get this done. Men with Fabry disease are more straightforward, right? Because they're not so complicated with all this exon activation stuff. So once they get men sorted a bit with the safety and how well is it working, some of the companies already have a commitment to move into women next. So your job is to keep yourself as healthy as possible, and then we can look at doing gene therapy in women as well. All right, what else? I'm looking here. I don't see anything else in the comments right now.
Does anybody else have any comments or questions for Dawn? John, thank you for the, I'm glad that you gave a some information about COVID-19. That was kind of cool, because I think that a lot of us do have questions about that. So thanks for answering that for us.
Sure, I'm happy to. I know that it's looming large for all of my folks down here, so I figured it would probably be a big deal for you guys as well. And I feel like when you think about Fabry disease, you think, oh, we all have bradycardia. Is that heart disease? Right. Ooh, I know that Fabry can cause problems with breathing. Does that mean I'm going to have problems breathing? And the answer is really, it's folks who are older or have, larger problems that we're mostly worried about. But everybody should take the hand washing precautions. Everybody should, listen to, if there's an outbreak in your area, looking at keeping yourself away from people as much as possible. No panicking, just, being safe.
Absolutely. So we have a couple, excellent job, great presentation. If there's nothing else and anybody else has any questions, then Dawn, thank you so much. We really appreciate your time.
Sure, thank you.
We are always happy to have you and see you on here as well. And we look forward to the next meeting you'll be at. Dawn will be joining us if all is going to be going ahead, which we will keep you updated on. Dawn will be joining us at the Fabry camp as well, so she will be there. But again, we will update everybody further with that. Just on a closing note, thank you for everyone who joined us with the Be Rare BU campaign. It was a big success again this year, so thank you. And if you have any more questions and you weren't able to get them answered today, please email me. I can always give them to Dawn too, and I know that she'll be happy to get that back to me. John King just said, great presentation, very informative.
Thanks, John. Bye, everybody. Thank you so much.
Okay, take care. Thank you, Dawn. Thank you very much.
Thanks. Bye.
Have a good night, everybody.